Our next speaker is Professor Carel Le Roux, who needs no introduction for anyone who knows anything about obesity. Carel has been a force for good for obesity for many, many years. He graduated from Pretoria in South Africa and completed his training at Barts and then the Hammersmith Hospital, which is basically the home of all things obesity 20 years ago. Carel moved to the University College Dublin for a chair in chemical pathology and metabolic medicine and is a director of metabolic medicine there. He's an ex-president of the World Obesity Federation. He's been a huge supporter of the UAE Obesity Conference, our efforts in the UAE, but also of the MENA Society. We're very grateful for your support and look forward to your talk. Thank you, Carel.
Thank you very much. Thank you very much for this wonderful opportunity. And I'm going to challenge you in the audience because, we're going to hear some amazing talks today, but I want us to actually think about what we are hearing and where we are, because it's only when we are challenging ourselves, and I love that reference earlier, that we have to look inside ourselves as well, that we will really be able to be the leaders, that we need to be. But I'm starting with this Hans Christian Andersen sort of depiction of the ugly duckling. And you will remember that, this little duckling, was looking different to the rest of, the herd. And where we are now with obesity is a little bit like that. We as healthcare providers have not been able to think about how to fit obesity. And I'm so pleased about the progress that we have made, that many of us are now saying that obesity is a disease, because that was very controversial only a few years ago. But although we are saying obesity is a disease, I'm not sure that all of us, including myself, are really treating it as a disease. And I think that's going to be the next step. Are we really treating this? Because it may be that understanding obesity is going to be the key for what we do. These are my conflicts of interest, and we work with lots of different companies, with nutrition companies, with pharmaceutical companies, and with surgical companies, because we don't think obesity is one disease. And therefore, it's incredibly unlikely that we're going to find one silver bullet that is going to treat this. But I think the reference was made already to Arya Sharma, saying that what we should stop doing is what's illustrated over here by our Greek character Sisyphus, where he was thrown into the depths of Hades and he had to roll this rock up this hill every day. And every day he got to the top of the hill, the rock would roll down. And that is what I have done and many others have done in the past when we asked our patients to eat less and move more. Eating less and moving more is a weight loss treatment. It is not a treatment for the disease of obesity. Because if you are truly treating the disease of obesity, what you will be doing is you will be removing the rock, right? You will not be helping the person roll the rock up better. You will be removing the rock. And that is what we see when we have effective nutritional therapies, pharmacotherapies, or surgical therapies. These treatments don't help our patients to adhere to lifestyle treatments. These treatments remove the disease of obesity, and that is going to be a fundamental opportunity that we have. However, we should also have sympathy with ourselves because we, as a community of medical providers that work in the disease of obesity, we have exactly the same response to science that most of the people outside of this room will also have. And you can see there's some people at the front that's really thinking deeply about the science. You will see that there's some people that's really frightened about this. The idea that Abu Dhabi is going to medicalize obesity. The idea that you're going to take, 22% of the population that yesterday didn't have any treatment, and today you're going to say, we are going to think of you as a disease of obesity. That's a big step, and that's very frightening for many people. And of course, there's people that don't care either. That's fine. Understand that there's going to be responses to this, and we have to work out how we can optimize this as we go forward. I've been asked to talk about obesity as a multi-organ disease, and that is incredibly easy because there's 220 diseases that are complications of the disease of obesity. Now, I trained in South Africa, and we always said that if you knew syphilis, you knew medicine, because syphilis is one of those diseases that cuts through all the systems in the body. But now when I train my medical students, I say to them, if you know obesity, you know medicine, because you actually will understand the impact on all of this. And you cannot go to any conference anywhere in the world when it comes to medicine and not have an impact if you're talking about obesity. So I think obesity is very important, and understanding that your job and my job is not to make people lose weight. Your job and my job is to actually improve the health of the patient. So we need to get away from this idea that our jobs is our weight loss. Our jobs is really for health gain, and preventing complications is one of the most important things that we as medical providers can do. Of course, another important thing that we do is to reduce the symptoms of people with the disease. But I'm going to ask you, just think about your clinic last week, when you treated other diseases. And I'm asking yourself, in which other disease do you think your job is to reduce the signs of the disease? If I treat somebody with diabetes, my objective is not to reduce acanthosis nigricans. If I treat diabetes, my job is to reduce the symptoms, polyuria and polydipsia, and to reduce the complications, be it microvascular or macrovascular complications. So we need to also get away and understand that our jobs in obesity, is not to reduce the signs of the disease. And the signs is, of course, the excess adipose tissue. But our job is to reduce the complications, the multi-organ complications, but also thinking about the symptoms. Now, we've been very privileged in Europe that the European Union has also prioritized obesity, and this is the SOPHIA project, where we work together with industry. So the European taxpayer gave half the money, industry gave the other half of the money, to really address this fundamental questions. Can we find the predictors of risk, and can we find the predictors of response when it comes to obesity? So what I'm doing here is showing you a linear line of, if we look at the x-axis obesity, and on the y-axis we have cardiovascular disease. And you can see that many people do go in a linear fashion. But I want to draw your attention to people, for example, on the extremes of this. So here we have a person who, for example, have a high burden of obesity, but a very low risk of cardiovascular disease. Over here, at the top, we have a person with much lower risks of obesity or evidence, but rather a high risk of cardiovascular disease. Do these people have the same disease? And when we actually are looking into this and using a UMAP, and this data has just been published in Nature Medicine earlier this week, what we can see is that we can identify at least 6 different subtypes of the disease of obesity. And those could be, for example, people who are discordant. Well, first of all, we find most people do actually track the higher the weight, the higher the risk. But you can also see those people who are discordant for hypertension, who are discordant for lipid profiles, who are discordant for transaminases, also hyperglycemia, and then inflammation. These people look differently when we phenotype them, and they also seem to behave differently when we actually are looking at those at highest risk. Here I'm just highlighting those patients who are discordant for inflammation. And what you can see is they have a much higher chances of heart disease, of stroke, and even developing type 2 diabetes. So maybe 22% of the people living in Abu Dhabi that we just hear don't have one disease. And, if we think back, if we were having this conversation in the 1950s about cancer, people genuinely thought that cancer was one disease, and we were going to find the cure for cancer. But what we see today is, even if you think about breast cancer, we now know there's 9 different diseases that happen to be inside the breast, and our treatments for them is very different. So maybe it's not surprising to us that we are trying to treat 22% of people in Abu Dhabi with one treatment, that is not going to work if we don't understand the differences. Because if we map this, further, for example, here I'm showing you the Novo Nordisk data with scale, you see exactly the same profiles that happen. Here I'm showing you the rewind data from Lilly, again with people predominantly with diabetes, exactly mapping onto it. But it's when we actually map this using the Swedish obese subjects study, these are patients who have had bariatric surgery, you can see that those patients in the SOS study also map onto this UMAP, but what we are now seeing is when we look deeply into those 2 groups, the one that's discordant for inflammation and the ones that's discordant for hypoglycemia, you now see that these patients are behaving in a different way. We've known for many years that patients that have diabetes lose less weight, be that if we give them lifestyle treatment, pharmacotherapy, or surgical therapy, and that is being borne out here. But what is new is that that group that were discordant for inflammation, remember the ones that were at highest risk of heart disease as well as stroke, they are also the group that respond the best to the surgical intervention. So for the first time, we are having insights that there are certain groups that are not only higher risk, but also may have a higher response rate. And that allows us to understand the heterogeneity that you and I see when people come to our clinic. Patients come with exactly the same visceral adiposity, subcutaneous adiposity burden, but yet some people develop diabetes, the others have no metabolic problems, but develop osteoarthritis. How can we explain this? Because what you and I see, the phenotype, may not fully explain the disease that we have. And it's better diagnostics that's going to make a big difference. But I did mention the symptoms of the disease, and here we have a young girl that was painted in 1680, and it shows you that obesity is not new either, but it also shows you that the stigma of the disease is not new, because she was found in the Spanish countryside, brought to the Spanish court, and the king used to bring her out when they had dignitaries visiting, and people looked at her and they painted her with clothes and without clothes. She was very strange because, at the age of 6, she weighed 70 kilograms. But the reason why I'm putting her up is if this poor girl comes with a mother or a grandmother to your clinic, she will say, "Please, doctor, help me because my child is hungry all the time." Right? And when I give my child food, my child does not feel full. Now imagine you take somebody that is hungry all the time, that doesn't feel full when they eat food, and you give them an eat less, move more approach. What will happen to any human being if they are hungry and you make them eat less? They'll become more hungry. What will happen to any human being if they are hungry and you make them exercise? They will become more hungry. Right? Now tell me one other disease in medicine that we treat, and by our treatment we make the symptoms of the disease worse, and by making the symptoms worse we make the disease better. Right? And you can't think about anything because there isn't any disease where we make the symptoms worse by our treatment and actually think that's a success. Right? So that also just challenges us in what we need to do when we treat this girl. And to understand this, all we have to think about is, where are the neurons that code for hunger and satiety? And this may challenge your neurobiology that you did at medical school, but most of those neurons sit in the subcortical areas of the brain. It sits in the hypothalamus, the area postrema, the nucleus tractus solitarius. These are all subcortical areas of the brain. And therefore, I now think about obesity as a neurological disease. Right? I think of this as something that has nothing or very little to do with the cortical areas of the brain, but it's really the subcortex of the brain that you and I are treating when we have effective nutritional therapies, pharmacotherapies, as well as surgical therapies. Because the word obesity comes from the Latin that means made fat as a result of eating. And genuinely, I was asked this question about 3 years ago, do I think overeating causes obesity? And I said yes. Okay? But now I'm challenging myself, because if you think overeating causes obesity, then you will try to make people eat less. But what we are seeing with our effective treatments now, that when I treat the disease of obesity, what happens is people naturally eat less food. Now I'm thinking that the disease of obesity causes people to overeat. And I am now using how much people eat as an effective readout for how effective my treatments are. Because in the past, we thought about obesity as an energy in versus energy out problem. So if you do that, then you will try to reduce the energy in or increase the energy out. But in fact, your house, whether or not you live in Northern Europe like I do, or in Abu Dhabi, your house has a perfectly controlled temperature. But the temperature in your house is not controlled by your good AC system, or in my case, my good central heating system. The temperature in your house is controlled by a thermostat that in my house sits in my kitchen, and I decide what the temperature of my house is. What I mean with that is that obesity is not a problem of energy in versus energy out. Obesity appears to be a biological dysregulation of the control of fat mass. So it is that thermostat that you turn in your kitchen that determines the temperature in your house. It is that biological control mechanism that we think sits in the subcortex of the brain that controls how many adipocytes and the mass of adipocytes you will carry. So therefore, our treatments should be to fix that biology. And we can address that with effective nutritional therapies, pharmacotherapies, as well as surgical therapies. What that will allow us to do is to step away from this ancient idea that obesity is a sin. This is Dante's Inferno, depicted by Botticelli, where the two mortal sins depicted here are gluttony and sloth. So European thinking was driven by this idea that, a sin is a willful act. And therefore, we have in good faith, we acted in good faith, but we tried to teach our people how to be better citizens. We used behavior therapy, like I need to teach you how to behave because you are just not intelligent enough or you don't know what to do. Okay? And that's driven by this idea, rather than understanding that what we are doing is we're dealing with a biological disease. And once we can fix the biology, then we can amplify this with our lifestyle treatments that's going to make the quality of life of our patients so much better. So we have had incredible data over the last 60 years. And in this orange line over here depicts how good lifestyle treatment have been since the 1960s. And pretty much, whether or not you have the world's best apps and the most connectivity, if you run the same studies in 2023, you get about the same results. The same is true for bariatric surgery. If you had a gastric bypass in the 1960s, you would have lost exactly the same amount of weight than if you have a gastric bypass in 2023 today. The efficacy of the treatment is the same. Of course, the safety of bariatric surgery is so much better, and that is why it's such an incredibly good treatment. But what has happened is that the pharmacotherapy has exploded, as we heard today, that has really changed, and this is a scalable treatment that we can now do. So I'm going to start summarizing, but I'm going to show you some new data that was just published in the New England Journal this week on the effect of treating obesity on multi-organ function. So here we have the phases of obesity, and again, I'm crediting Arya for coming up with some of this originally. And what you can see, first of all, we have the first phase, the so-called development phase, and this is where we can really interact and actually help patients, and this is where we can prevent the disease. This is phase 1. So taking healthy people who are normal weight and having them, in a state where we can keep them. However, some people develop the disease, and what you will see in the second phase, this is a stable phase where the disease, are effectively, people stay at the same elevated body mass index. And at this point, patients were treated with the medication. And you can see in this case, patients went from 108 kilograms down to 83 kilograms. And this we call the dynamic reduction phase. But then patients were continued with the medication for another 2 years, or 3 years in total. And we call this another stable phase. Now, this is just an insight what you are hearing now in your own clinical practice. The minute you start the treatment over here, people say to you, you must be the best doctor in the world. And you feel like Rocky Balboa, right? Because the patients are saying, for the first time in my life, I'm not hungry, I feel full, I'm not thinking about food, I'm eating smaller portions, and I'm enjoying the food. I'm eating the food I like. I like chocolate, I eat chocolate, but instead of eating the whole slab, I only eat 3 blocks, and I love it, right? And you are amazing. Right? And then the same patient come to you, when they enter at this inflection point, when they go into the stable phase of weight maintenance, and they say to you, doctor, either the medication isn't working or you are a terrible doctor. Okay? Because at this point, I am now feeling hungry. I'm thinking about food again. I'm eating bigger portions, and, I'm still liking the food I'm eating, but clearly this medication isn't working anymore. But if the patients stay on the medication, what will happen is their weight will not change, but their experience is changing. Okay? And that allows us to understand, what we are doing with these treatments. What we're merely doing is moving patients from an elevated, stable homeostatic point to a new, stable homeostatic point. But the patient's experience is different. And of course, your challenge and my challenge is not going to be to start people on the treatment. That's the easiest bit. But what is your stay time? Can you keep people on this treatment for 3 or 4 years? Because only then are you able to see these benefits. So here I'm showing you the hemoglobin A1C, the impact on type 2 or on prevention of type 2 diabetes. Look at that hemoglobin A1C in pre-diabetes coming down to normoglycemia, reducing the risk of developing diabetes by 94%. Let me put it in other terms. If you take 100 people that live in Abu Dhabi with pre-diabetes and you give them this medication, only 1 will develop diabetes. 99 will not develop diabetes. What is the difference when it comes to blood pressure? And Ari and myself had this discussion. This improvement is dramatic when it comes to the impact of hypertension on so many of the other organs that we are interested in, be it the kidney, be it the brain when it comes to stroke. What is the impact when we look over here, I need to look at SF36, when it comes to functionality? And that is what drives the quality of life of the patients that you treat. And again, from your perspective, this is what's going to drive the quality of life for the population. The fact that people come back and say, I can play with my children or my grandchildren, I can go out with my friends, this functional gains that you can see, despite the symptoms changing, the patients are maintained. You get the benefit and it maintains the benefit. The challenge, however, for you and me is that patients come to our clinic, or at least they come to my clinic, because they want to become thin and they want to become happy, right? And what I'm suggesting to you is I cannot do that, and I will challenge any of you in the room that think you can make people thin or happy. Right? Because if you look at the data, and now I'm showing you the SF36, the mental domain, for the same study, what you can see in the SF36 and the mental components, there has been no change despite 23% weight loss that is maintained over 3 years. So what this suggests is that when I treat somebody with a statin or an ACE inhibitor, I do make them healthier and I do make them live longer, but I also don't change the mental domain of the SF36. You know, we need to get away from this idea that we will make people thin or happy, and we need to focus that we can make people healthier and more functional. And that's also just being honest with our patients about what it is we can achieve and what we cannot achieve. So I'm going to summarize and suggest to you that the future of obesity care will include chronic treatment aimed at health gain, not weight loss. And that chronic treatment could be nutritional therapies, pharmacotherapies, as well as surgical therapies. It's recognizing the biological basis of this disease and that we need more and different treatments for the subtypes of the disease. And ultimately, we need to never blame our patients for their disease or if they don't respond. But we need to understand how can we actually treat those resistant diseases of obesity, not only to prevent them, but also to treat them effectively. Thank you very much.
Thank you very much, Carl, for a thought-provoking talk as ever. We've got time, I think, for a couple of questions, if anyone wants to come to the microphone. So whilst there are microphones actually on. Thank you. Can you switch it on, please?
Hello. Hi, Carl. Nice to see you again. Okay, Carl, what do we answer those patients that they are living with obesity, having their biochemical and clinic tests perfect, and they are already middle-aged? And when you talk to them about the healthy lifestyle, physical activity, and being concerned about their weight, they are not encouraged because you say, I'm good, I'm just doing perfect.
Yeah. So I think there's a large number of patients who have the disease of obesity that don't have any metabolic sequelae, but they may have, for example, mechanical or mental sequelae. And from that point of view, we need to look at all 220 complications and work out what is the driver. So I ask all my patients in clinic, I ask them a question, I say, do you think of yourself as healthy or unhealthy? And then they would say, well, I'm unhealthy. And I say, why are you unhealthy? And about 8 out of 10 will say, because I'm fat. So, well, you know, if I put a backpack on your back, I put 3 big rocks inside your backpack, I'll make you heavy, but I won't make you unhealthy. Why do you think of yourself as unhealthy? And what they tell me next is the most important question, because they think deeply and then they may come up and say, actually it's because I can't do things, or because I'm worried that my father or mother had diabetes or developed cardiovascular disease. So what we then find is that is the value proposition. That means this is what that individual patient would like, and that's where we need to drive them to. Because in 1 year from then, you would like to ask them, do you think of yourself as healthy and unhealthy? And they would say, I'm much healthier because I now can play with my children and I'm not worried about developing diabetes or heart disease. So I think although we are seeing all this incredible data, we always have to bring it back to the individual, because what we have understood in the recent past is that weight loss is not enough of a value proposition to continue the treatment, be it nutritional therapies, pharmacotherapies, etc. So we need to understand what is that value to the patient that allows them to continue the treatment in the long term. And you know, if a patient says to you, you know, I can't perceive any value, then I wouldn't force them. Right? You know, but say to them the door is always open and we can actually make those things better.
You already answered the extension of my question of them not like in this case, what do you suggest to them? Like they are half and a half convinced, they know they have obesity, but at the same time they feel well and they are served well.
Yeah.
In the case you said that if they dysfunction, like not being able to tie their shoes, but there's somebody else at home tying their shoes for them and all the rest, then they are convinced. So what do you tell them? Thank you.
Thank you.
So one more quick question. Can you switch it on, please?
So we all agree that obesity is a disease with many symptoms, and it is the cause of overeating. Like the question that always comes to my mind, why the prevalence is increasing, why it's not stable, since it is a disease like any disease, why is it increasing? It's just the availability of food, or?
So I think this is the most important question in our field at the moment, is we don't understand what is driving the disease. I personally do think that the environment, both the food environment as well as exercise, plays an important role. And therefore, preventing the disease with those approaches are incredibly important. What we do know is when we take those issues away from people that have the disease, we have very little impact. So it's about focusing on preventing the disease with these public health measures, which I think is excellent, but understanding that the impact on those people that already have the disease, that is not as impressive. So we need to do more prevention and we need to do more treatment, and these are not mutually exclusive from each other.
Thank you.
Thank you very much, Carl. I'll say the same comment I sent last year. If we manage to break the cycle, so mums who've had bariatric surgery have healthier babies with less risks of obesity, hopefully, I mean, the data's tiny, but hopefully that will break the cycle.
I agree.